Good afternoon, everyone, and welcome to the October 2023 Western Neuropathy Association webinar. It is our pleasure to have a presentation on low-dose naltrexone by Janelle Jones, and she's a pharmacist. She's at the Gold Country Compounding in Auburn, California. And as a compounding pharmacist, Janelle helps to formulate medications in different doses and forms to accommodate individual patients. Over the years, Janelle has seen the results of such specialized medication formulation, and she's excited to share her observations about low-dose naltrexone. She recently spoke with the Western Neuropathy Association's Auburn support group on this topic, and it was very well received. So the Western Neuropathy Association in general is very happy to have her back and to share more of all of the information she has virtually. Please understand this webinar will be recorded for later review on the Western Neuropathy Association website, and please hold your questions to the end of the presentation. Thank you, and without any further ado, Janelle, it's all yours.
Why, thank you for that great introduction. Yes, I am a compounding pharmacist, owner at Gold Country Compounding, and I've had the great joy of working with low-dose naltrexone for the past 10 years. I have seen some absolutely miraculous, life-changing outcomes with the medication, and one of my greatest goals is to spread awareness about the medication. So I'm going to go ahead and share my screen to look at some slides, and we'll kind of get into and explain what low-dose naltrexone is and how it works and what patients can expect from it. Not everyone's familiar with what a compounding pharmacy is. We are a little bit different than a regular retail. We actually make the medications by hand, specifically for one patient. Everything is in small batches with just one patient in mind, and that gives us a lot of flexibility to be able to make things that are not available traditionally. One of those things is low-dose naltrexone. Today, I'd kind of like to go over just a little bit of where the low-dose naltrexone came from, how pain medications and pain works, how the LDN works, some of the diseases and diagnoses that it can help with, and then a little more information just on low-dose naltrexone itself. Just a little disclaimer, this is all personal experience. Any actual medical advice needs to come from your physician. So, history of naltrexone, first made back in the 60s. It was FDA approved at a 50 milligram dose for opiate addiction. And then it was started to be used in the 1980s, 1985, and so on at the low dose that we're going to be discussing today. It's come quite a long way, and it's a lot of patient-led movement, word of mouth, pharmacists, patients, and doctors talking to each other to get awareness of the medication out. Back in 2016, there were over 300,000 patients worldwide taking it. I have not been able to find updated numbers, but I'm sure that number has grown tremendously. So going into how low-dose naltrexone works needs a little bit of an explanation on how pain works in our body. Opiates are exogenous painkillers. So they are things that we take like morphine and hydrocodone that work on pain receptors to reduce pain. Our body also makes endorphins and enkephalins, which are our own natural painkillers that work at those same opiate receptors and give us our own natural pain relief. So, how does low-dose naltrexone work? It's a little counterintuitive. In the body, we have our receptors that cause an action, and then there are chemicals that work on those receptors. An opiate or one of our own natural painkillers work on the pain relieving cells, something like a key fitting into a lock turning the lock and creating an action. So in this case, we're switching a receptor on to provide pain relief. And low-dose naltrexone is actually the opposite. It is a key that fits into the lock, but does not turn on the receptor. It's a blocker. It prevents other opiates from working at that site. So if you think about it, it's almost counterintuitive in that you're using a medication that's an opiate blocker, which you would think would increase pain levels because you're blocking pain relief. And in effect, we are. But our brains are extremely sensitive. Even if taking a low dose naltrexone in a very small dose that only lasts for about 4 to 6 hours, the brain is going to recognize that there is a deficiency in endorphins and will get busy upregulating the production of endorphins and endorphin receptors around the clock. Basically, we're tricking the brain into making more of its own natural painkillers. And this is a continuing progression where the brain is going to be increasing the number of endorphins and receptors continually, not just that 4-hour window while the low dose naltrexone is in the body. So that's how low dose naltrexone can be very helpful for chronic pain disorders. The first that comes to mind is fibromyalgia. But chemicals are kind of interesting. They have hands that don't really overlap, even though they're the same, and each one is good at doing something different. So the left-handed naltrexone chemical is great for increasing endorphin release, helping with immune modulation. The right-handed one actually helps work on the immune system. And what I mean by that is in the immune system, you have many receptors on all of the different white blood cells and other immune cells. It's the toll-like receptor's job to recognize intruders such as bacteria or viruses, and then to signal an alarm that releases inflammatory chemicals. That leads to swelling, redness, and inflammation. And in an autoimmune condition, like this angry little puppy there, they overreact to any type of stimulus, including the body itself. So basically, the body is setting off an alarm, saying that there's an intruder when there is, in fact, not. The dog is barking uncontrollably. When we take the low-dose naltrexone, it calms the immune system down. It blocks some of those toll-like receptor functions and makes it so that the signal isn't set off, that the dog isn't barking at the wrong people. It calms everything down, which reduces inflammation and pain. And that is why it is so very good at helping with just about any chronic inflammation, autoimmune condition, or other. I love that picture. There is also a large amount of research going into low-dose treatment of cancer, either as a standalone or more commonly added on to the current chemotherapy or radiation regimen. A lot of really interesting information available on that, but that would be a whole nother seminar. So this is a list of some of the conditions and pain schedules that are currently using low-dose naltrexone. It's a huge list, and there's actually a lot more of them. Needless to say, if you can think of it, low-dose naltrexone will most likely help. There are hundreds of clinical trials and many more in the works being done on low-dose naltrexone. I just wanted to touch on some of the interesting research articles that are being done, and some of their outcomes, just to give an example of what's going on. So, most frequently, I see naltrexone prescribed for chronic pain and fibromyalgia. It's being studied by some pretty big names, including Stanford University, University of Southern California, and Stanford uses that actually quite a bit. One of my favorite outtakes from that first study is that patients taking it have reported their lowest ever average pain score after just 90 days of starting the medication. So pretty impressive there. Crohn's disease, IBD, IBS, ulcerative colitis are also extremely well received indications for low-dose naltrexone. It's nice with these two because under a scope, you can actually visualize the improvement in the skin's tissues. Multiple sclerosis is also a very common diagnosis for low-dose naltrexone. In fact, the first time I heard about low-dose naltrexone was from a patient that had been able to go from taking 12 different pain medications almost on a daily basis down to just one low-dose naltrexone pill and regaining her quality of life. It also has some interesting applications for depression, anxiety, and PTSD. It's commonly used through the veterans offices, and there's a lot of ongoing studies there too that are really interesting. Arthritis is great because we're talking about inflammation. It is fabulous at reducing all types of inflammation. And the nice thing too is it can be added onto a lot of therapies or other anti-inflammatories, and the two together work even better. This is an interesting graph. You'll see that low-dose naltrexone circled in yellow towards the top. The left-hand side of the chart is how popular the treatment is, the right hand being a less popular, and the effectiveness being towards the bottom, increasing effectiveness towards the top. You'll see that low-dose naltrexone is at the very top of the effectiveness chart, although unfortunately, it is not widely known. We'll get there though. There is currently not nearly enough information directly on neuropathy itself. There are many reports of patient cases, but no large study scales. I personally have had patients that have had great success with it. This is a case report of a patient that started low-dose naltrexone, and within 6 weeks, their pain score on a scale of 1 to 10 had decreased from 8 to 9 down to 1 to 2. I believe that low-dose naltrexone has a lot of opportunity to benefit neuropathy because typically a lot of the pain from neuropathy is associated with inflammation, especially inflammation of the lining around nerve cells. And if we can get that inflammation lowered, then there's a chance for the nerves to function more properly and to have less pain. So, elephant in the room. So far, it sounds like I've been trying to sell snake oil. I'm talking about a medication that no one really knows about that I'm promising will help with so many different things. So, what's the catch? What would I want to know as a patient? First, is it safe? yes, it is overwhelmingly shown to be incredibly safe medication. When we're taking low dose naltrexone, we're typically talking about a dose around 5 milligrams. The FDA approved full dose naltrexone is a 50 milligram tablet in which patients take up to 300 milligrams per day with very few side effects. There are basically no severe adverse effects reported. And in a study of over 11,000 patients, there was no evidence of increased risks or serious events compared to placebo. That's basically saying it's about as safe as you can possibly get, safer than Tylenol. Well, does it have side effects then? Fortunately, not many. About 77% of patients experience no side effects at all. Some experience insomnia, vivid dreams, headache, and those symptoms typically resolve within 2 to 4 weeks of taking the medication. Drug interactions, very few. Primarily, we're concerned with opiates because they work on the same receptors that the naltrexone does. So if they're taken at the same time, they're going to cancel each other out. Neither one is going to work as well as it should. And if someone were dependent on opiates, if they were to take an opiate blocker, it could cause a sudden withdrawal reaction. So patients need to be opioid free. Additionally, consultation with a doctor would be appropriate if someone had a severe pre-existing liver condition. So it's got to be expensive, right? Well, not really. So low-dose naltrexone, like I mentioned, is not available at a regular pharmacy except in that 50 milligram tablet. So traditionally, naltrexone is made in a compounding pharmacy by compounding pharmacists like myself. Most insurance companies don't cover the medication, but in general, the naltrexone costs about $30 per month. That's just the regular cash price without insurance. So I know that there's not a lot of information on there or out there in general about low-dose naltrexone. You don't see any commercials for it on TV, but it is being studied by quite a lot of very prestigious institutions. Brown, Duke, Harvard, Stanford, UCLA. These have all prescribed and are researching low-dose naltrexone. This was a study done back in 2019. It was a poll of 1,100 patients that were starting or using low-dose naltrexone. On a scale of 1 to 10, they were asked if they had improved symptoms. 20% of those patients said that they ranked it a 10, that they had strongly improved their symptoms. And another 42% said that they had an improvement of 6 to 9. So over half of the patients had greatly improved symptoms. The other interesting thing is besides just the symptoms improved, the decreased pain, patients also, about half of them reported an increase in energy levels and 40% had an improved mood. It's pretty good odds. There is a lot of information out there to be learned. These are my 2 favorite resources that are nonprofit organizations that promote research and awareness of low-dose naltrexone. I highly recommend both of them. There are also several Facebook groups. I love the low-dose naltrexone for chronic illness and infection group. Extremely active and helpful information. On a personal note, I just wanted to share my story with low-dose naltrexone that is not neuropathy, but is my real world experience with how incredible this medication is. I had struggled with polycystic ovarian syndrome. It's an infertility disease. I had worked with doctors for over 7 years, trying to conceive. We had done medications, injections, all sorts of things, and nothing was helping. I had a patient come to me and ask if low-dose naltrexone would help with endometriosis. And in the course of helping her with that, I found out that it can be used for infertility. 4 months after starting therapy myself, I was pregnant, and now I have an absolutely amazing 2.5-year-old boy that is the light of my life. So I will for always and ever be grateful the patient that told me about low-dose naltrexone. And I want to encourage all of you to share this with the people that you love, because I can guarantee you there's at least one person you know that this could be life-changing for. And I'm always, always happy to talk about it. So if anyone ever has questions, feel free to contact me at Gold Country Compounding. Do we have time for questions?
Let me get back here on terms of getting online here with you.
All righty.
All right, so thank you so much for an excellent overview of this amazing, sounds like amazing drug. I've already written down all kinds of things to talk to my doctor. My problem also is that I'm a Kaiser person, so I don't know how hard it's going to be to get my Kaiser doctor to listen to this, but I hope to try. So anyway,
Some do. There are
pardon?
some Kaiser doctors do prescribe. Yep.
Good. That is good to know. Okay, so that's a positive. So let me get to the question and answer. So so Catherine has decided to be the main person asking the questions.
Okay.
So okay, so wow, is it personal experience is amazing, she says, and she just thank you for sharing that. Catherine Stencil is one of our board of directors, and so and she's very excited about this presentation, which is excellent. So she also asked, can you talk more about the compounding pharmacy and the difference between a regular drugstore pharmacy and the compounding pharmacy?
Sure. So if you think back to the way that pharmacies started, where you had powders and scales and mortars and pestles, that's basically what we do in a much more advanced lab environment now. So we actually weigh out active ingredients, mix things together, fill the capsules, make the ointments, make veterinary medications that taste like bacon. We make everything from scratch and by hand. So it's very, very hands-on and very rewarding. The great part about it is we have infinite number of options versus being limited to what is available at the regular retail pharmacy.
Okay. So another question from Catherine is, how do we get our doctor to accept this, just like I was asking, the LDN can work on neuropathy? Many do not know about this and are not willing to research to educate themselves. And that's my own personal experience also.
That can be a tough one. And I find that there are 3 types of doctors. There's doctors that know about it, love it, and prescribe it anytime they can. There are doctors that have not heard about it, but are willing to do some reading and give it a try with a little prompting. And then there are doctors that have not heard of it and are not willing to put in the time to learn about it. Hopefully your doctor is one of the first 2. If they're in the middle boat where, they might be willing to learn about it and prescribe, there are some great resources available on the that LDNresearchtrust.org website. There are prescribing guides, patient information guides, and prescribing guides for the doctors, as well as the information there. It's a great thing to print out and take to an appointment. I'd also encourage anyone that is looking for a prescriber to contact their local compounding pharmacy. The pharmacy is going to know which providers in the area already work with low-dose naltrexone, and they should have resources available as well to help patients get that prescription.
how do you know, how do you contact your compounding, quote unquote, pharmacy?
Uh, quick Google search,
Oh,
compounding
okay.
pharmacy near me. Yeah, that's most likely the easiest way to do it.
Okay. Okay, here's another question. All opioids cause either itching or vomiting. Would naltrexone cause similar reaction?
Possible, but not likely. Um, that is a very common side effect of opiate medications. Um, what I can say is that the naltrexone is taken such an incredibly low dose that the only reason it works is because our brains are so incredibly sensitive. So it's such a low dose that I would not expect and have experience with patients that do have that reaction to opiates, have not had reactions to the low dose naltrexone.
So
So possible, but not probable.
sorry,
No problem.
the dosage that you're really talking about is about 5 milligrams?
Yeah, less than 5 milligrams
Oh,
daily.
less than 5. Okay. So here's another question. Contraindications with warfarin and other heart medications, such as Entresto or Farixa, etc.
None. Works
Good,
well with those, no interaction.
good. Another one is, do I need a prescription from an MD even though my insurance won't cover LDN?
Yes, you do still need a prescription. It is a prescription medication.
Good. Okay. Also, the comment that Catherine also wanted to put in here, which I think is really important also for all of us to see, is that we have several support group members that have successful use with the LDN, and I think that's amazing. So that's really good.
Yes, it is.
Okay, so let me see if I can get down here to a few more. Okay, so wow. Okay, so chat is, oh, I'll let Lindsay work on the chat is disabled on my end. That was a comment by one of the attendees. So next one is, what type of doctors would prescribe LDN, GP, neurologists, others that we could ask for help?
All of those doctors do. I find the doctors that prescribe it most frequently are in some sort of pain management field.
Hmm.
Because it is so helpful for specifically for things like fibromyalgia, they're much more familiar with its use there and recognize that the anti-inflammatory effects from it can be very useful for other conditions. But any type of a prescriber can write for it.
Okay. Next question is, I started on LDN 1 week ago. I'm supposed to take 1.5 milligrams per day for 2 weeks, then double that to 3 milligrams. I haven't felt relief of symptoms yet. When should I, if it works for me?
That has got to be the hardest and most frustrating thing. And it's really important to remember that it's not the drug relieving pain. It's the drug encouraging your body to heal, to reduce the amount of inflammatory chemicals it's releasing, and to increase the amount of endorphins and endorphin receptors your brain has. So we're waiting for your body to heal and to work more properly, and healing takes time. In general, patients start to really notice an appreciable difference within 6 to 8 weeks, sometimes 3 to 6 months. I always beg my patients, minimum 3 months on it, and please, please, please give me 6 months, if not a year.
Okay, thank you.
You're welcome.
Next question, does it work for numbness and electric sensations also? I have idiopathic small fiber neuropathy, and my main problem is not pain, but progressive numbness, etc. Would it actually reverse the disease?
So I don't think it would reverse the disease. I think it would help maybe slow progression and or help with some of the symptoms of it between like numbness, burning, pain. And that's because we're reducing the inflammation, which can go a long way. And I want to say I read an article recently specifically about small nerve, and that looked like they were having some good results.
Oh, good. That's good. Next question is, my MD prescribed 6 milligrams of LDN because At the time, I didn't feel 4.5 milligrams was helping. Why is recommended doses 1 to 4.5? Should I talk to my MD about decreasing dosage?
That's an interesting one too. So historic use started, most of the research started back in the 80s, was done at 4.5 milligrams. Not entirely sure how they came to that number, but because of the way research has been done since then, that is by far the most commonly prescribed dose. Some patients do better with a lower dose, and that is one of the reasons that we usually have patients start somewhere between 0.5 and 1.5 milligrams daily, and then they work their way up. Some patients do better at a higher dose, which is typically a patient that has more inflammation versus generalized pain. So I do think that 6 is an appropriate thing to try. And then the other thing for the back of that patient's mind is that sometimes splitting the dose twice daily can be more effective, specifically for inflammation. So a lot of different options out there, and it really comes down to the patient and what we're trying to do.
Okay. Next is a topical cream with amitriptyline has worked. At what point will I know when I need to look at an LDN?
I've actually recently read an article that was showing that the low-dose naltrexone is just as effective as amitriptyline in neuropathy specifically. That was an oral dosage. I would say, though, if you are getting efficient relief from your amitriptyline, stick with it. If you if you still feel like you have room for improvement, it's not an either or. You can safely take naltrexone with the amitriptyline or in place of, but it's giving you another option, something else that might help. So it's worth looking into at any point.
Okay. Are there online doctors that prescribe?
Yes, there are online doctors. I'm not going to promote any of them specifically, but I have worked with several online companies that actually do a very good job of caring for their patients. They're very informative and very thorough. So that is definitely an option on how to get a prescription.
Next is what recommended doses ramping to avoid side effects, 0.5 for 2 weeks, then 1 milligram for another 2 weeks, etc. What is maximum dose that you have seen, 5 to 10, any ramping down needed to come off suddenly?
Gotcha. Okay. So typically the starting dose is based off of the condition we're treating. Patients that have a possibility of having a flare or a worsening of their condition, we usually start at a lower dose, like the 0.5 milligram, and work up slowly. An example of that would be a patient with Hashimoto's thyroiditis, where they have antibodies that attack their own thyroid, suppressing thyroid production. If you were to start at too high of a dose too quickly with the low-dose naltrexone, it could suppress those antibodies so quickly that they swing and become hyperthyroid instead of hypothyroid. So there are situations where we're concerned with that, and to be on the safe side, we just start low and go slow. I have seen and heard of patients taking up to 12 milligrams daily. Not a lot of research done at those higher doses. Like I mentioned, most patients take about 4.5 up to 6, maybe 9 milligrams daily, but it's, once again, it's not the amount of naltrexone that's being taken, but the effect of having that opiate receptor blockade for a short amount of time. So we want a low enough dose that you're not going to feel pain from having the opiate receptors blocked, but enough of a dose that your brain recognizes that there's a deficiency, so it'll produce more receptors. So fine balancing act that's just a little bit different for every patient.
And perhaps for every diagnosis almost.
That too, yep.
Yeah. Next one is, can you get LDN from an online pharmacy?
There are several very large scale compounding pharmacies that can dispense to all 50 states. So, yes, with a prescription, you could have one of those large pharmacies mail a prescription to you.
Okay. So here's a couple more questions here. It says, is taking the 4.5 dose one time a day enough, or does it need to be spread out over the day? You mentioned something about 4 hours.
Gotcha. The vast majority of patients take it one time a day, typically at bedtime, but any time of day is just fine. Um, Once you've taken the pill, it is only in your system for about 4 hours before it's metabolized. That's the 4 magic hours where your brain is sensing the underproduction of endorphins. And then it will continue to produce more endorphins throughout the entire day. So usually once a day dosing is perfectly accurate.
And next part of that question is, if someone wants to go off of it, can it just be stopped, or does it need to be tapered off? I have heard it does not need to be tapered off.
That's correct. No need to taper off. You can quit cold turkey at any time with zero negative effects.
Next one is, I heard that you start with 1.5 and then increase to 5. How long until you feel the effect?
A lot of patients will start at 1.5, 3, 4.5, or 5. In very broadly, most patients start to feel the effects within 6 to 8 weeks of starting. I have had a couple of lucky patients call me back the next week to tell me that they're already feeling better. So
Wow.
it's different for everyone, but generally 6 to 8 weeks.
What should the prescription state as far as dosage and timing?
That's completely up to the prescribing doctor. The vast majority of patients take 4.5 milligrams once a day. But once again, doctor's discretion.
So, are you familiar with LDN use in erythromegalia, a very rare neurovascular disease? Wow.
No, I'm sorry. I have
pronounce-
not heard of that diagnosis specifically. I
Okay.
would recommend that they go to ldnresearchtrust.org. There is a searchable section for all diagnoses there, and then any associated research or patient testimonies or links like that. So it's a great resource for something specific.
How often should I take LDN for MS-caused neuropathy?
Unless the doctor says otherwise, the traditional once daily dosing.
What is the likelihood of insurance eventually paying for LDN? What would it take for that to happen?
Unfortunately, slim to none. Something that I should point out is that naltrexone itself is FDA approved. It is approved at the 50 milligram tablet, and it is specifically approved for opiate abuse or alcohol abuse. What we're working with the low dose naltrexone, it is an off-label use, which means the specific dose as well as the diagnosis being used with are not specifically FDA approved. And insurance companies tend to only cover medications that have a specific FDA approval. So I don't think they ever will, unfortunately. However, for most people, it is relatively affordable, and there are some ways to get it less expensive.
Okay. So you already answered the question. Is anything we can do personally to help the LDN, sort of backlog, or the red tape part of it? I think you just answered it.
Yep.
Any
Unfortunately, go ahead.
Any dizziness or vertigo side effects? And I have poor balance, and dizziness can cause, excuse me, falls.
It is a possible side effect. Very rare. I want to say 1 to 4% of patients. I would also say with a concern like that, that taking it right before bedtime would be an appropriate time of day to take it, because you should be in bed. Um, and and like I said, it only lasts in the body for about 4 hours, so it should be well cleared before you get up in the morning.
Okay. Next one is I have fibromyalgia and have taken 90 milligrams of Cymbalta daily for many years. In your experience, is naltrexone treatment started while on Cymbalta?
Yes. They work together very well. And I've had several patients that have the longer they've been on the naltrexone, the least they've found that they don't need the Cymbalta as much anymore and have been able to taper down and eventually stop their Cymbalta dosing. I would not recommend stopping the Cymbalta before starting the naltrexone. You wouldn't want to leave yourself in a space without that to help there. And they are safe to take together. So your doctor and you can come up with a plan on how to safely do that integration.
Okay. So let's see, the next one does it only work if the SFN is caused by inflammation, i.e. if it's inflammatory neuropathy?
That's a great question, and I don't have a great answer. What I can say is that almost all pain conditions have at least some component of inflammation that would be helped by reducing the inflammation levels. Um, Also, you would be increasing endorphin levels, and that is going to help with any type of pain. So no, I don't know that it would help with all types of neuropathy, but I think it's very worthwhile to try something that is so safe and reasonably priced.
Should LDN be taken at night or morning to avoid insomnia side effects? Does it matter what time of the day you take with or without food? Does food matter?
I always recommend to my patients to try to start by taking it at bedtime. For most of my patients, it actually helps them sleep. There are unfortunately about 10% of patients where it causes insomnia. It can just be switched and taken in the morning to avoid that side effect. It is equally effective, morning or evening dosing. That does not matter. And then for the vast majority of patients, it doesn't have any stomach upset or nausea side effects. So with or without food doesn't matter with it. Food does not interfere with absorption. If someone is prone to upset stomach, I would say go ahead and take it after a meal, just to be on the safe side.
This one says I was, excuse me, I was on very low, I was on very LDN. I think that means, and I was on LDN for 6 months, 1.5 to 2.5, and never got over the intense nightmares and insomnia. I had to suspend it. Is it worth trying again?
Definitely. Just take it in the morning time. It'll be well out of your system by the time you go to bed. And you won't have those unpleasant dreams.
Good point. I have a noxal polyneuropathy and a form of CIDP. Will this help?
Don't know. I can't give you a promise. I'm not going to give anyone a promise that it's going to help. All I can promise is it's worth trying. And it's, yeah, really worth trying.
Okay. Next is I have been taking 4.5 for 4 months. No change in my PN. Should I try higher dose or just accept it is not working for me?
Please, please, please stick with it for at least 6 months, preferably a year. I know that's a long ask, but as long as you're not having any negative side effects from it, it's worth sticking with just to see. Unfortunately, it does not work for everyone. My other suggestion would be to think about more than just what you're taking it for specifically. Has your mood improved? Are you sleeping better? Do you have less anxiety? Do you have more energy? Look at those things too and see if you feel like there's been any improvement there. After 6 months at the 4.5, if you haven't really noticed any kind of improvement or if you're having any kind of a side effect, you could think about discontinuing the medication then. But giving me at least 6 months.
The next one is, can you be on it indefinitely? Or does it, and does your brain get exhausted and producing all those extra endorphins?
You're never going to upregulate to a point that it's dangerous or anything like that. I've continued to stay on it, even after having my son. I feel like a happier, more energetic person on it. So yes, there are many patients. I have one patient that started it in the late 80s for MS, and she's taken it every day since then, and she will never stop taking it. And she's had no negative side effects and no disease progression.
Wow. So there's one that says that I have 3rd stage kidney disease. Would LDN be a problem or cause any issues at 4.5 milligrams?
It would not. It is cleared by the liver and does not have any special dosing requirements for kidney.
And then here's actually a reference by one of our board members, Glenn. Glenn's really got tons of information about all kinds of things. So I think we'll just leave that one posted along with the video, because it's a very long connection. I'm still, next one says, I'm still trying to figure out what dosage to start with and then how to determine if I should increase or decrease it. Doesn't seem to be working. Up, down, question marks.
Gotcha. The most common dosing regimen is to start at 1.5 milligrams for 2 weeks, 3 milligrams for 2 weeks, and then 4.5 milligrams ongoing. Unless you're having negative side effects at the 4.5 milligram dose, I would recommend sticking with that dose up to that 6 months. And unfortunately, it's just kind of a waiting game to see if your body is going to respond to it. But unless there's any specific reason to adjust up or down from that, that is the dose that is usually recommended.
I says, here's another. I did take it in the morning, very low dose, and still had horrible nightmares and insomnia after 6 months. I may be a lost cause.
Possibly. Or another option would be to talk to your provider about starting at a significantly lower dose than that even. And see if you can find a dose low enough that you're not having the vivid dreams, and then possibly being able to slowly increase your dose at a rate that your body can tolerate, to get to an effective dose that is not causing those unpleasant dreams.
Okay. So here's a comment also by Glenn. I think I'll read this one. Remember, LDN is designed to help with pain symptoms. It is not designed to help with other sensory and certainly not motor symptoms. The mechanisms as described is to increase the body's own endorphin pain fighters. And he was just trying to help emphasize what you were saying, I think.
Yes.
So the next question is, and comment is, I have been taking 90 milligrams of Cymbalta daily for the past 6 months. I thought we already did this one. So I'm getting off. So you already answered this one, actually, I think, that you don't want to get off Cymbalta.
No, not that. I mean, you might be able to eventually, but they work very well together. So I would recommend following doctor's advice, but safe to take together and usually a good combination.
Yeah. Next one is, and I have cirrhosis and am on LDN. You said do not take with liver disease or failure.
That is a caution, not a blanket statement. Definitely whomever follows your liver health needs to know that you're taking it. I would say the vast majority of the time, even with liver disease, it is still safe to take naltrexone, but it needs to be something that the doctor is aware of so that they can monitor appropriately.
Are there any blood tests one should have annually or other time periods while on LDN?
No, it is so safe. There are no monitoring or tests required.
What kind of education do you need to be a pharmacist, and what additional education do you need to for a compounding pharmacist?
So all pharmacy degrees now are a doctorate program. So 4 years undergrad, 4-year doctorate degree, and then compounding is additional residency past that.
I have an autoimmune disease that kills my blood platelets. Would LDN cause an increase in my immune system? Have heard it increasing an autoimmune disease or exasperating it.
Typically it's the opposite. Typically it will settle down an autoimmune condition without suppressing the immune system. So it takes it from being overreactive to properly reactive. So it is helpful for most autoimmune conditions. And I will go ahead and just refer back to that ldnresearchtrust.org for more specific information.
I have mixed connective tissue disease and frequently experience flares. Have you seen incidences of increased flares or connective tissue pain, such as tendonitis?
I'm sorry, I don't have personal info or a personal experience with that.
Okay. I have serious non-diabetic neuropathy, fortunately with minimum pain, just numbness and tingling from my feet up to my ankles and as well as my hands. Will it help minimize these issues?
Definitely has the possibility of reducing that tingling, especially if we can take some of the pressure inflammation away from the nerve tracts. It can help signal more properly. And sometimes that can relieve some of the tingling sensation, not necessarily some of the numbness that could be associated with like complete dysfunction.
And with, one last thing, it says stay on, and this is a question, stay on Cymbalta even if it's not working, the LDN. Or no, maybe meaning Cymbalta. I'm not sure. Doesn't say LDN.
It sounds like the question is the Cymbalta's not really helping. Do I stay on it anyway?
Yeah.
And that's going to be a great question for your doctor, because if you're taking it and you have experienced no improvement, you and your doctor can decide if it's worth sticking on another medication. If the doctor feels like you're not getting any benefit from it in general, then yeah, time to move on and try something else that might be beneficial.
Does it help a lot of people with complex regional pain disorder or hypersensitivity?
Yes, there's a lot of information out there on that. And it's been very, very helpful.
Okay. I have a question for myself. I'm on a lot of gabapentin and still have a lot of pain. How would you relate that to the taking of gabapentin?
Gabapentin definitely has its place, and hopefully it's doing some benefit.
It is doing some good for me, for sure.
But once again, it's something that could be safely taken with a naltrexone.
Oh, good.
And I would imagine it's not taking away your pain completely, the gabapentin that is.
No, it is not.
So you would still be able to have some kind of an indication of whether the naltrexone is helping your condition. If you're noticing less and less pain, and you could take less and less gabapentin.
That would be nice.
Right?
Yeah.
A couple side effects there. So
okay, thank you.
We're trying.
Yeah. Now I think we've gone through all the questions, and that was a lot. And I think thank you so much for all your responses and you're taking the time to answer the questions and provide us with the talk. We really appreciate it. And like I said, this has been recorded, and so it will be on our website for those who want to review it again or who want to recommend to someone else to take a look at it.
Yeah.
So again, thank you so much.
Definitely my pleasure. And I do want to remind everyone that you do know somebody that this is going to help. So think about it. Let other people know. I want everyone to know that this is available and out there.
Okay. Thanks again. And take care. Bye-bye.
Bye.
Okay, that ends today's webinar. If you have any, please take a look at the recording on the website. Thank you.